Good morning, everyone, and welcome to today's webinar sponsored by the HiBAR Research Alliance. I'll be the moderator of today's one-hour event, and I'm joining you from the University of British Columbia, where I support the development of collaborative research programs. I'd like to begin today by acknowledging that the land on which UBC is situated is the traditional, ancestral, and unceded territory of the Musqueam people, and we are very grateful to live and work together in this beautiful place. So this is the 28th webinar in a series tailored to researchers and administrators who are interested in what we call highly integrative, basic, and responsive research, HiBAR research. Our previous webinars are all available for viewing on the HRA website, which can be found at hibar-research.org. Also online is a brief 3-minute explainer on what we mean by HiBAR research. And as a quick recap, what we're advocating for are projects that embrace two key dualities. First, they incorporate both academic and societal leadership, working in partnership, fueling innovation through cognitive diversity and a deep understanding of the societal context. And second, they integrate academic purpose with societal purpose, creating new knowledge with academic rigor while applying it to practical challenges. So these aren't new ideas, and HiBAR research has been undertaken at many universities, historically correlating with significant impact in society. And our opportunity now is to learn how to do this well and to do more of it. So just before our featured presentation begins, I'll take a minute to explain today's structure. We're going to spend about 25 minutes hearing from Dr. Salkoudian about 3 distinct approaches he's taken to collaboratively develop robot-assisted surgery and diagnostic technologies. Then we'll have another 20 minutes for Q&A, followed by an opportunity for Tim to wrap up with final takeaways. So let's get started. I'm pleased to introduce today's presenter, Dr. Tim Salkoudian. Tim's a professor in the Department of Electrical and Computer Engineering at UBC, and he holds both the Canada Research Chair and the C.A. Laszlo Chair in Biomedical Engineering. His research focuses on ultrasound, teleoperation, and image-guided surgical robotics. Over to you, Tim.
Thank you very much for the introduction, Kira, and thank you for the HiBAR organizers for inviting me to present. So some brief disclosures. I am co-founder and had a past management role at Sonic Insights, which is a UBC spin-off that commercializes technology that my colleague Rob Rowling and myself have developed. And I do have collaborative research agreements that do not involve really any personal funding to me that are with the University of British Columbia. So what I was thinking of doing is presenting 3 examples of different industry collaboration models that I have been using in my research, stressing what I consider to be a reasonable HiBAR example. These all have to do with the application of novel imaging methods and image guidance to serve communities, surgeons, hospitals, and eventually leading to improve patient care. So one relatively recent project has to do with what we call human teleoperation. Remote communities have a lot of difficulty accessing healthcare. For example, from Haida Gwaii, in order to have an ultrasound during pregnancy, you may have to take a ferry for 6 hours to reach a hospital. You cannot do back and forth in the same day. So we're interested in developing a solution that is easy to implement. And in the past, teleguidance systems, which are based on essentially smartphone graphics, have been used, and also robotic teleoperation. In fact, I was one of the first ones to propose and use that technology over 20 years ago. What we do in this project is we replace the robot that is normally controlled by the experts seen here on the right with a person who acts as a cognitive safe robot. And what that person does is in a mixed reality display helmet, they see an image of a virtual transducer shown in green. And their job is solely to move the actual ultrasound transducer to make it coincident with the virtual one. The virtual transducer is controlled at a distance, can be hundreds of kilometers away, by an expert, a sonographer or a radiologist, who basically maneuvers that virtual transducer in response to the ultrasound images and to the forces measured against the patient. This is an example of how this works from the lab. We see here the transducer now shown, the virtual transducer shown in white, the ultrasound image on the left that follows the actual standard ultrasound transducer interface that can be controlled at a distance. And basically, we have shown that we can, in fact, control, we can scan patients at a distance. So in this project, the technical development was done solely by academic researchers. And we obviously did evaluate the system, develop the system jointly with healthcare personnel. This was funded primarily to begin with by an NSERC Discovery Grant, which is a curiosity-based research grant, but it later on became one of the projects in UBC Rogers 5G partnerships. Rogers is internet and mobile phone service provider in Canada, and their partnerships has been very useful in providing government and community engagement for us, funding with MITACs, federal government agencies, and technically, they have provided help with communications infrastructure, and this is now becoming a collaboration as we are approaching testing at various communities. Our goal here is to produce a validated technology package that is thoroughly tested in remote communities. We have plans for Haida Gwaii, which we have had already a pilot study, successful pilot study at 750 kilometers away from our lab. But we will be partnering with groups in Saskatchewan who are interested in virtual health and who have access to robotic remote ultrasound, and we plan to compare our human teleoperation technology with ultrasound, with robotic ultrasound. A second area of interest and work in my lab is elastography imaging. This pertains to the imaging of mechanical parameters of tissue, or if you want, a form of remote and objective quantitative palpation. And we started this with providing real-time strain imaging. On the bottom right of the image, you see a standard B-mode ultrasound image of a tissue phantom, and next to it, a strain image that shows what's really underneath the tissue. And that image is obtained by slightly compressing the tissue with the ultrasound transducer to produce strain. We have extended this work to actually use a mechanical vibrator, like a massage table, that basically can shake parts of the body or the entire abdomen to generate images of the prostate shown in the upper left corner of the screen, on the left with ultrasound, on the right with MRI. We have images of the liver that you see in the top right of your screen, where you see shear waves that are generated by the vibrating table in the liver. And basically, we use the local wavelength of the shear waves to determine liver stiffness. We've applied this technology to multiple organs, including breast. And here we have a breast scanner that basically produces tomographic volumetric ultrasound images of the breast. And you can see in tissue phantom again how these shear waves are obtained by our methodology and can generate the stiffness in highlighted yellow patches onto the blue background. So in this project, the technical development was done mostly by academic researcher. My colleague Robert Rowling and myself have been working on this for many years. But we have had a sequence of various partnerships with industry, primarily with Ultrasonics, which was a Vancouver startup in the area of ultrasound, later on purchased by Analogic, which was later on purchased by GE Healthcare. But we also worked with Philips Healthcare and with Exact Imaging, other ultrasound machine manufacturers, both in Canada and the United States. And we have received research infrastructure from Philips, for example. We've received machine and transducers that have many thousands of array elements arranged in a matrix that allows for real-time volumetric imaging. So this type of real-time volumetric imaging can be used to map the shear fields in the body and get essentially a quantitative stiffness number. And we obtain software from Ultrasonics. We work together to define what we need in terms of a research interface. And in fact, that was extremely successful, both for researchers and for the company, which sold many systems to researchers worldwide. This became actually a standard for over a decade for ultrasound research. But we also had exchange of technical ideas and many beneficial outputs that includes technology for both researchers like us to build upon, but also for companies. And very, very valuable to the companies has been the fact that personnel that was trained by us was later on employed by the company. And this also led to technology licenses to Ultrasonics for real-time strain imaging, which was actually the first implementation of a clinical strain imaging worldwide, and to our spin-off company, which produces liver assessment device called DataCure. Now, I want to concentrate primarily on robotic surgery. And when people hear robotic surgeries, they might imagine some autonomous system that actually works on the patient. In fact, all of this is fully teleoperated, built upon pioneering work that was done at the Argonne National Labs in the late 40s by Raymond Gertz. We see here right and left-handed controls that basically allow somebody to maneuver parts that are actually in a very radioactive, hostile environment. This idea was taken up by a company called Intuitive Surgical, who developed what is known to be the Da Vinci system, which allows minimally invasive surgery in patients and makes the job of the surgeon a lot easier. The surgeon, instead of performing laparoscopic surgery with essentially distally maneuvered chopstick-like tools, there is a mapping from the instruments that you see in the green box underneath the robotic system directly to the hands of the robot, of the surgeon, who basically maneuvers left and right hand controllers, and their motion is mimicked by the instruments with 6 degrees of freedom. This has been very successful, and the Da Vinci system provides excellent ergonomics for the surgeons. They have filtering of tremor, very sophisticated instruments of any imaginable kind. But the major promise of such a system is not only the dexterity, but it is the ability to register the instruments to the patients, and therefore also register the instruments to preoperative images. So our research goal here is to take preoperative images, which you see here stuck onto the Da Vinci console as printed images, and insert this into the surgeon's view so they can have an understanding of what lies underneath the tissue. So I'll give an example of where this might be needed. Approximately 85% of prostate surgery in North America is carried out with robot assistance. This means for now mainly the Da Vinci system. And the goal of the surgery is to remove the prostate, which lies between the bladder and the pelvic floor, while causing the least possible damage to the nerves and the sphincters that are responsible for continence. And the primary goal is always in cancer surgery is oncological success. We don't want any cancer left behind, or we basically should not have any positive surgical margins that appear in the histopathology taken from the specimen after surgery. A secondary goal is to have functional success, and that means to recover both potency and continence after surgery. Now, my numbers here are relatively old, but they haven't changed much lately. We have surprisingly high rate of positive surgical margins, as well as complications that appear after surgery. And what we are trying to do is provide the surgeon with a geometrical 3D view of what is happening under their endoscopic camera, what's happening underneath the tissue, for them to be able to make a better selection between oncological and functional success. And our system employs an endorectal ultrasound, which is controlled by the Da Vinci instrument. So we register the ultrasound transducer to the instrument, which can be used essentially like a mouse to control the ultrasound plane sagittally through the rectum, imaging the prostate. We can see here how this might look to the surgeon. On top, you have the endoscopic view to the right on top. You see the bladder, the Foley catheter through the bladder, the prostate in front of it, an artifact of the instrument, and basically an ultrasound image of the prostate. In surgery, this appears as a live ultrasound image, which is shown underneath the endoscopic view. This endoscopic, this view also contains the preoperative MRI image, which is shown in a transverse view with the red patches that you see showing the location of cancer, both in the posterior part of the prostate as shown now in the middle image, and also in the anterior part of the prostate as shown on the left. And we have shown the benefits of using ultrasound in doing anterior bladder dissection, bladder neck dissection, and apical dissection. And we have integrated in this a view of the MRI, which is shown as follows. As the surgeon uses their instrument as a pointer to go through in that they see in the endoscopic view. The ultrasound image changes, and on the left you see the corresponding MRI, which shows the segmented prostate, which needs to be fully taken out of the body, and shows an ultrasound and shows the MRI view, which is acquired preoperatively, which has much better definition of where the cancer is than in the ultrasound images. Our system, though, is only a partial augmented reality system. Essentially, what you see is a view of images through the segmented prostate that appear underneath your endoscope view. So the surgeon has to mentally use the pointer of the instrument, shown in blue here, in order to orient themselves with respect to the endoscopic view, which is shown in the window above. For a true augmented reality view, shown here with respect to a prostate phantom, what we would like to see is both the camera view and a cut through it that allows the surgeon to basically mentally or accurately localize critical anatomy and tumors underneath the tissue surface. Now, for such direct overlay of preoperative images, we need to have a tissue 3D map that shows the tissue topography, so that the corresponding MRI image can be cut and displayed seamlessly underneath the endoscopic view as the surgeon maneuvers his instrument as a computer mouse. We also need to have tissue tracking in real time, because the process of registering preoperative images to the patient is fairly lengthy, and we do not want to repeat that more often than necessary. So we want to have computer vision-based techniques that allows us to perform, to track the pertinent features of the tissue after they have been registered. And finally, there is a problem of hand-eye coordination. The instrument that the surgeon sees while using it in surgery or as a pointer has to be registered with the endoscopic camera view. Otherwise, the features, for example, a tumor that is pointed at by the instrument does not appear at the correct location. So we started a more intense collaboration with Intuitive Surgical to try to address this problem. And initially, we followed a model in which the research was done mainly in our lab and at the hospital, when we had basically similar Da Vinci systems in our lab to the one in the hospital. So my students could basically develop technology in the lab at UBC, and then that would be ported seamlessly to the operating room. Basically, to carry out this research, we needed to have certain information from the Da Vinci system in the OR. This is provided by what they call the Research APR, or Application Programming Interface, that streams out the instrument locations for us to use in our development. Now, the methodology for augmented reality was of interest to both our lab and Intuitive Surgical, and we found a student who was interested in and became jointly supervised with the company personnel. And the student, Adam Schmidt, has done a great job at developing technology to track tissue in real time. So we have here basically in green, these are features that are detected by computer vision. They are sparse, so they can be placed anywhere on the tissue or on instruments, and they can be tracked in real time at 10 frames per second on a fairly pedestrian GPU. And with many, many points. If we have fewer points, then obviously the computing time scales with this. In addition to developing technology that's based on the most modern AI techniques, we develop the methodology to actually validate tissue tracking. So we took tissue as shown in these videos, and we used IR labeled little tattoos on tissue that can be shown with only a specific IR camera that's available on the Da Vinci system. And what we have done is we have created a large data set of clips of Da Vinci system used to maneuver tissue, with a beginning and an end of each of the video clip. And we have made this data set public so that computer scientists and engineers worldwide can use this data set to develop AI methodology and test it. And we have also a challenge to do this at the leading medical imaging conference, where researchers worldwide are basically developing algorithms that we test on this data set, and then we can rank and evaluate which algorithms perform the best. So these are the typical results of tissue tracking. It's been published in several conference and journal articles by Adam, and has been fairly successful, and it's starting to be cited, well cited. So for this project, the technical development was done actually jointly by academic, both engineering and medical investigators, and industry researchers. And the partnership with industry, in this case, Intuitive Surgical, provided co-funded research infrastructure, very useful research interface, funded student, both at UBC and with annual 3-month internships at the company. And we received basically very different perspectives and expertise in hourly meetings every 3 weeks for well over 3 years. The outputs include a very useful public database of surgical video clips, challenge that can be done to develop the best methods, vastly accelerated research and new projects for at least 3 PhD students in my lab and also internally at Intuitive Surgical. And not negligible at all, tremendous infrastructure for teaching and training. So in my undergrad, co-listed with graduate level robotics course, I have every year at least 3 groups of 5, maybe 4, maybe more groups that have access and can play with the Da Vinci system that has a research interface. And this is exciting to them and provides tremendous value for their education. So in terms of maybe starting a discussion, I think that projects can evolve from being mainly academic to becoming collaborative and finally really highly integrated. Developing research methodology that is both basic and responsive and leading to downstream applications which are very interesting: augmented reality, tissue tracking, instrument tracking. You can imagine a surgeon who wants to keep track of a tumor. In computer vision, marking X marks the spot, then the computer vision takes care of tracking the feature for them. And to evolve such a project into a high bar project, certain things really have to happen. And we must have students who are excited by such opportunities, and not only excited, but also maybe incentivized by having a stipend that is significantly higher than what most students can receive. We need to have stable relationships with long-term funding. PhD takes a minimum of 3 years. In good cases, 4 years, often 5 years. There have to be IP agreements between universities and companies and hospitals involved. And it took us almost 2 years to develop the initial agreement with Intuitive Surgical that led to our purchase and their donation of equipment to UBC. It took us approximately a year and 3 months to get the agreement for the specific student that worked closely with us. You also need to have a company that is truly at the forefront of technology, so they're also open to collaboration and they're interested in and can afford basic research. Clearly, many project types can and they should exist. The project that I described is not the only one that I have that involves Da Vinci robots, but it is the one that involved the high bar type of collaboration. Also, we need to have funding agencies that are willing to support relatively short-term research that has very direct application to a specific company, but also more basic research. And there has to be an understanding that really the flow of knowledge is not necessarily from university to industry, but it is clearly both ways. And because of this, the fact that, for example, we have a national project here or in the US or in Europe with a specific company, there are advantages to government agency co-paying, even if the company is not necessarily registered in their jurisdiction. So I hope this can start a bit of a discussion. I would like to acknowledge student contributors that were specifically listed here. There are many more than I have listed, but for this particular talk. And also collaborators at Vancouver General Hospital in the Faculty of Medicine at UBC, as well as Simon DiMaio, who is a manager of user interfaces at Intuitive Surgical, and Omid Moharary, who is a manager in research at Intuitive Surgical. obviously lots of funding has been used for this type of project. Thank you so much.
Thank you, Tim. Got a lot of questions here for you, but really appreciate you talking through all of your research and those great examples of different collaborative models. I'll start off with one here. Interested to know if you could describe a bit more the role that your non-academic project partners have taken in determining the key research questions to address, and specifically interested in the elastography imaging, where you had several different industry partners engaged in that project. In industry sector leaders like GE and Philips, did you see a need to work through a process to ensure all partners had a common outcome goal, a common ambition in mind, or was there value in bringing partners to the table with potentially competing interests in the technologies?
Yeah, so the work started primarily in our lab and was seeded by really our curiosity. Rob Rowling and I had a student, and we have seen some work on strain imaging, and as my having a background in control systems and parameter identification, I thought that we can use a more rigorous inverse problem type of approach to finding tissue parameters, as opposed to just hand-excited strain imaging. That was the seed imaging, and it so happened that at the time, Ultrasonics was a fresh startup in Vancouver, and we needed to have ultrasound with a research interface so we can modify the pulse sequences for the images and obtain the high frame rate sampling that we needed for quantitative elastography. So with Ultrasonics, we worked in a way in which we helped them understand what is needed from a research perspective, and to develop a research interface that they could sell not only to us, but to others. And they, in turn, knew more about the ultrasound machine architecture, and they provided us with advice on how to best use the machine for what we needed to do. This allows us to fund the project in a collaboration that was essentially fully paid by NSERC. It was an NSERC strategic grant. The company benefited hugely, though. They have sold not tens, but hundreds of machines with research interface that from work that started in our lab. We actually received an NSERC Synergy Award for that work. Then Ultrasonics was acquired by Analogic, which was acquired by GE, and we had some continuation of that work for breast imaging using with Analogic. We have not continued that work with GE. By then, we had also spun out our technology for liver imaging to Sonic Insights. What is also very interesting in that collaboration is that we had some needle imaging work that we're doing with Philips using their equipment and our know-how of image processing to create a couple of very interesting PhD theses. And during one of their visits, Philips mentioned that they'd be very interested in working with us to develop volumetric imaging based on matrix arrays, because it was, in a way, a match made in heaven. We had the technology of doing rapid measurements, and they had the transducers that were could produce actually streaming volumes. So that started as a co-pay. Philips funded the project, and then NSERC CRD program, which later on became Alliance, co-funded that. It led to what I think is now the state of the art in quantitative tissue, quantitative volumetric tissue elasticity imaging. I hope this answers your question.
Thank you. I also wanted to double click on some of the demonstrations and testing in community that your team has worked through, and curious to learn whether these demonstrations and validation testing in Haida Gwaii were able to uncover any unexpected requirements for the technologies or any unexpected use cases, and really keen to hear more about how you interacted with the broader community in those instances.
Yeah, so I have to give Rogers a huge credit for this, because we have started to work with indigenous communities very early on, with the help from the Citizen Services Ministry of the BC government. And Rogers has created a plan for us that essentially pushed us to very early on discuss how we might approach testing in the community. And we had visitors to the lab to see and understand the technology, and we worked with them to develop our ethics approval and planned the testing of the system. We didn't really have any major negative surprises. Our system was still in development and obviously have certain bugs. I think that what we learned during that study was more about the needs for not in Haida Gwaii, but the needs for the expert interface, and how can we make the sonographer interface be as much as possible to what they're used to working with. I think that we started with not very ambitious scans. This was just an abdominal aortic scan that has some measurements associated with it. But for example, a patient is supine. We didn't really have to move the patient the way you might have to do it for a kidney or a cardiac echo. So our plan, and we have a grant proposal in progress with the NSERC Alliance societal program. Our plan is to evolve the technology from simple scans to more complex scans. Always we want to have some objective measures. So when we did the test in Haida Gwaii, we in fact collected data on how well we could track the transducer, what were the tracking errors. We collected NASA TLX questionnaires from the patients, and for the novices, how we're doing the scanning, and from the sonographers who were doing the scanning. And we collected images which were then evaluated by radiologists to see which ones are of diagnostic quality. And basically, we found that essentially almost everything, 93% of our scans were of diagnostic qualities, with the remaining 7%, the major reason being body habitus. Essentially, the patients were difficult to scan in the first place.
Interesting. You also mentioned a role, you wear two hats now. You have an academic research role and you're part of a spin-off venture. How has that additional hat and being part of a spin-off spin-off venture looking to commercialize technologies. How has that influenced how you approach designing research projects or research methodologies today?
So I'm trying to keep multiple projects in my lab based on my interest, based on the interest of students, and also I am trying to have my students not to step too much on each other's toes. So there hasn't been a conflict. The only conflict is really my own bandwidth of how much I can handle. In terms of my experience with the spin-off, I've had probably financially for both UBC and for myself and my colleagues, we've been very successful with the sale of technology in the haptic space. And looking back at that, it was very, very easy. It was patenting, it was negotiating, and after that, it was royalties. Very, very easy. Spin-off, on the other hand, requires really a tremendous commitment. Had to do business plans. I had to learn how to get export licenses. I actually delivered a system to a university in Peru, and I had to go help them set up. So in a spin-off, you have to be a jack of all trades because you don't have the funding to have others do. So it basically consumed a good part of one sabbatical and at least half of another one from my time. Now, the advantage is that, you know, Sonic Insights now has over 30 employees and they all pay taxes in BC, which is another level of satisfaction. So it's not only that the technology has been transferred and it looks very much as what we had in mind in our lab, but it is also employing people, including my students, but many others, and that's very satisfying.
Fantastic. You mentioned in another project a co-supervision model with one of your partners. Can you talk a little bit about some of the specific steps you took to make sure that your partner was deeply engaged in the decision-making process and supervision process for the project? And also share a bit more about what your experience was like as the faculty co-supervisor.
Yeah, so this is it's always difficult to find a project in which company is willing to jump with both feet. If you look at if you look at how the company Intuitive Surgical has evolved over the years, I believe they probably had close to 25 years of over 60 or 70% profit margins. So this is a company that really does have the resources to a research project in a very big way on their own. I think it's important to for them to find a project which is basic enough that they don't feel that it can interfere with their business plan and product plan. The specific area that we chose is one in which also patenting is of relatively little value. The computer vision field is moving at such an astonishing rate that, you know, every 6 months you have new AI models that improve by a few percent on the previous ones. So very difficult to keep track with that. So they understand that what's important for the company is to keep on top of developments. And the way I have multiple projects in my lab, they have multiple projects in research, and some of them they do collaboratively, and some of them they don't. So the choice of project was one in which being open is actually beneficial because you get all the community working for you. So planning took quite a while. It took us, as I said, maybe a year and 3 months. While Adam was already my student, it took us that time to finalize the research and fellowship agreement between UBC and Intuitive Surgical. And during that time, we have developed the project in collaboration with Intuitive Folk. Now, it does help that the co-supervisors from Intuitive have been lab alumni. Simon DiMaio finished with the Governor General's Gold Medal Prize for his thesis. He went on to Harvard and then to Intuitive Surgical as research manager. And Omid finished his PhD in 2015. So we did have a personal relationship, but in general, the company has been fairly forward-looking. They have taken, for example, old Da Vinci systems, and they have made those available to the community with a research interface. There, I believe, over 70 such systems available worldwide, including UBC, Stanford, Berkeley, Europe, lots of places, Japan, and so on.
You mentioned also that having a grad student that's focused on a high bar project could require a higher stipend. Can you talk a little bit about the different types of expectations you set for your students, whether they're on a high bar project or not? Or what are the different characteristics you're looking for in a trainee to handle and manage those types of projects?
Yeah, so there are always trade-offs, right? So the higher stipend comes with certain drawbacks on IP development. So the students have to understand that the usual policy for 50% ownership of IP that is typical of UBC would not apply to you if you were to choose to double or triple your stipend by one having a higher stipend while at UBC and two having a real salary for 3 to 4 months a year while you are on internship with the company. Students do understand that. I think that there are many independent ones who would prefer to develop IP and be able to hold on to it the way a faculty member would. And there are others who feel that the additional learning they might have an exposure to company products and know-how is worth this sacrifice, if you wish.
Tim, you've worked with a number of partners over quite a long term and across multiple project areas. How important do you think it is if I'm pursuing a new partnership to go into a new collaboration with an ambition to show quick wins, to then be able to lengthen out that partnership over the long term?
I think this applies in general. I think it's very important for any research project to have a long-term goal that is fairly ambitious. And at least in my mind, I'm trying to focus that around applications. Not everybody is of the same opinion or likes doing this. And with this long-term project, I always tell my students that it's very important to have 6 months milestone to go with the long term. And basically, I think the same holds for collaboration with the company. If anything, they are a little bit less patient. Maybe the 6 months ought to become 4 months, but they also need to understand that this is basic research, and it's very difficult to have necessarily quarterly updates. What is even more challenging, I think, for biomedical research, though, is finding the medical partners that have the patience to stick it with you while you develop technology. Because essentially, you go into the OR and you discuss the issues they're facing and, chat about how they see the future and how you see the futures. And then obviously from pretty much all surgeons that I worked with initially, they will ask you, well, so can you have this done for us in the next 2 weeks or 3 weeks or a month? And then they realize after they work with you for a while that it actually is 1 or 2 or 3 years as opposed to weeks. So in this type of multidisciplinary collaboration, I think there is a need for patience on all sides, but there's also a need for milestones, not more than 1 at every 6 months.
Tim, we've got 3 more minutes, so I think it's over to you for any final words of wisdom or 1 or 2 key takeaways that you want to leave the group with today.
Yeah, I think the key takeaway is that moving towards high bar projects is can take quite a bit of time. It requires established partnerships, and it requires a lot of communications and a good personal relationship is very helpful in all these projects. And to build that type of trust, I think that it's necessary for all parties to take some deviation from their immediate or personal or lab goals to make this happen. So people have to like meeting and working together.
Dr. Salkoudian, thank you very much for taking the time today to share your experience with us. Also, thank you to everybody who attended today's webinar and submitted questions. Really appreciate everyone's time today.